I will talk for about 25 minutes. Am I right?
That is correct.
Clock just.
And then we have a discussion. And then Tariq and Jaz will talk for 25 minutes and then discussion.
So will it be okay if I give my talk and a discussion and then I leave, or should I stay? What do you think?
I think you have to criticize Tariq for his presentation. So
Critique.
for that, yeah, you expert critique. So
we have the same name. You can't criticize Tariq.
We'll have a nice critique.
Okay, I think we are on time. And I don't think Randy is not yet here. Okay, let me just check. Can you message him, Tariq, and see if he's able to join or he's sleeping or what?
I think you might ask Imad probably to do that.
Oh, no. Oh. अरे मेरा कंप्यूटर नहीं है, मुझे पता नहीं क्या करना है, इसको बंद करना है। I think we are 2 minutes past. Tariq Sahab, I think we can start and they can join us later on and we can have discussion accordingly. Yes?
Yeah.
Tariq?
Yeah.
So, welcome guys. Today we have, as part of our international PSN webinar and WFNS Trauma Committee session, we have a webinar in which we have two well-known international speakers. We have Professor Tariq Khan, who's the chair of the Trauma Committee of the WFNS Trauma Committee, and he's a well-known figure, has done a lot of work among lower middle income countries, and he's going to be talking about the state of affairs for trauma in lower middle income countries. Tariq, please start.
Yes. Thank you very much, Salman, for giving me this opportunity to talk on a subject which for me is very important. I've been working very hard for it to try and get the neurotrauma management guidelines for low and middle income countries. Guidelines are very important to set the minimal standards right from the site of accident, to agree on the minimal standards of care, and it should be a system of care which grows as trained personnel and resources become available. Of course, it's very much dependent on the local resources and profiling the local data and geography, transport difficulties, and looking at the resources available, personnel and equipment. Back in 1997, I had proposed, along with Dr. Faika, a set of guidelines to the Pakistan Society of Neurosurgeons, but unfortunately, nothing came of that. We know that the neurosurgical burden in LMICs is 74% of surgeries are required for TBI in LMICs, and it is the number required. It's not the number which is done. And 89% of surgeries are required for traumatic spine injuries in LMICs. So the guidelines have to be holistic, starting from prevention to pre-operative care, emergency room, ICU and theater, ward care, and most important again, rehabilitation. So we did a study with the Asian Australasian Society of Neurosurgeons some time back, and 6 hospitals from Pakistan, Indonesia, and India took part. And we got some very interesting figures. We did a helmet and seat belt survey, and you could see that majority of the people were not wearing, the patients who arrived were not wearing helmets or seat belts. And of course, we know that we have this thing in our mind that we have to get to the Guinness Book of Records. We have the most number of people on a motorbike, and we think that one helmet would protect everybody. So we started this very important program, a head injury prevention program. I think it was required in the country, and it is being done in most low and middle income countries. And for that, we do seminars and poster competitions whenever we have a meeting of neurotrauma in Pakistan, and also now internationally, also in the ICRAN. And recently, the Neurotrauma Committee paired with the Think First International Injury Prevention Foundation to spread the word on prevention of head and spine injuries. And our first seminar in Pakistan was done in last year in November, and it was a very successful public awareness seminar there. So then we looked at important pre-hospital care, and we looked at who provided emergency care at the site of injury. And we found that majority of the patients were seen by the pedestrians or the lay persons. And also then we looked at whether did a nurse or doctor accompany the patient to the hospital. And we found that majority had no accompanying nurse or doctor in the ambulance. We know that 50% of patients who die from TBI do so within 2 hours of injury, and 40% of pre-hospital deaths are potentially preventable. If you look at the data, 59% of trauma deaths occurred in the field in high income settings compared to 72% in middle income and 81% in low income countries. If you look at Kenya, only 52% of patients arrived in the hospital within 30 minutes and 72% within 1 hour. Sorry. So, and we looked at the duration of surgery from the time of accident. Again, we found that most of them were operated more than 24 hours later. So we know that the treatment is geared towards prevention of secondary injuries and rehab, and secondary injuries like hypoxia, hypotension, edema, raised ICP lead to increased mortality, and longer the delay, greater the mortality. So the pre-hospital care is one of the most important aspects which has to be looked at, and we need to support our pre-hospital services in all LMICs. Now, the in-hospital management is guided by GCC monitoring, CT scan, ICP monitoring, pupillary response, and the goal is supportive treatment and prevention of secondary damage. The Brain Trauma Foundation guidelines, which are evidence-based, are initially general maneuvers, head elevation in neutral position to avoid venous congestion, normothermia, sedation, volume resuscitation. First line therapy, CSF drainage, hypocapnia, mannitol administration, 3% saline. And then second tier, high dose barbiturates, intense hyperventilation, increase in mean arterial pressure, mild to moderate hypothermia, and then decompressive craniectomy. Again, the level 2 evidence for Brain Trauma Foundation is that biofrontal decompression has been shown to reduce ICP and stay in ICU, but not the extended Glasgow outcome score at 6 months. Also, that level 2A evidence that a large frontal temporoparietal decompressive craniectomy, at least 12 by 15 centimeters, reduce mortality and improve neurological outcome. In level 2B, data showed that ICP monitoring data reduces the hospital stay and 2 weeks post-injury mortality, and that the ICP should be monitored in all salvageable patients with GCS 3 to 8 after resuscitation with CT changes. And ICP monitoring, even in normal CT having 2 or more features, age greater than 40, unilateral or bilateral motor posturing, or systemic blood pressure of less than 90. So what are the guidelines for the lower and middle income countries? Majority of severe traumatic brain injuries globally are managed without ICP monitoring. Even 23 to 89% cases in high-income countries. There is no recent literature to guide management in non-monitored patients. A large part of literature comes from well-equipped larger centers in high-income countries. There are no resource-based guidelines in LMICs to guide severe TBI management. So the Neurotrauma Committee had formed a subcommittee headed by Andres Rubiano to look at this, and they developed these stratified guidelines that they were put in the Journal of Neuroscience and Rural Practice, and the recommendations of the Consensus Committee for the Management of Traumatic Brain Injury in pre-hospital emergency department surgery and intensive care, and was beyond one option for treatment of traumatic brain injury, a stratified protocol. And then we wrote a commentary, myself and Dr. Mukhtar, and we said that resource-driven protocols are more important for neurotrauma management in lower and middle income countries. So from evidence-based, we were looking at resource-driven protocols because we were not monitoring ICPs here. We all know the important trial, BEST trial by Randy Chestnut, which provided the only tested non-ICP monitored treatment protocol. And this trial compared ICP monitored patients versus non-monitored imaging and clinical examination protocol, ICE protocol. And this paper revised a consensus-based management protocol for the treatment of severe traumatic brain injury based on imaging and clinical examination when ICP monitoring is not employed. It was recently published by Professor Chestnut. So what is consensus revised ICE protocol? The CREVICE. It's not a substitute, but a supplement for empirical evidence, effort to provide for the vacuum left by absence of evidence-based guidelines, and it was developed using the Delphi technique, and many intensivists and neurosurgeons are part of it. How are we doing it here in our center? So we're doing decompressive craniectomy on admission with certain protocols, and then patients who are admitted and whom we can pass an interventricular catheter, we do ICP monitoring and manage them that way. Or we are using the ones patients we cannot put in an ICP monitor, we use the CREVICE protocol. So our indications for decompressive craniectomy are CT findings of diffuse brain injury, with or without contusions, effacement of basal cisterns, midline shift, GCS of 9 to 12, or a drop of 2 degrees from previous, and age less than 70, because we know that there's a very high mortality over 70 years of age. The CREVICE protocol depends on the Marshall score on CT scan, the interval CT scans, clinical score, GCS, and neuro worsening, and pupillary response. And the management response is 4-tiered. So I'm sure you all know what is the Marshall grading. It depends on the cisterns, the midline shift, presence or absence of a mass lesion. So intracranial hypertension is suspected and treatment is recommended in the presence of one major or two minor criteria. And the major criteria are compressed cisterns by the CT classification of Marshall diffuse injury 3, midline shift greater than 5 millimeter, again Marshall diffuse injury 4, non-evacuated mass lesion. And the minor criteria are GCS motor score of 4 or less, pupillary asymmetry, abnormal pupillary reactivity, and CT classification of Marshall diffuse injury 2, that is basal cisterns are present with midline shift 0 to 5 millimeter and or high or mixed density lesion of 25 centimeter by 3 or less. And the neuro worsening is defined by a decrease in the motor GCS of 1 or more points, B, new loss of pupil reactivity. C, interval development of pupil symmetry of greater than 2 millimeter or bilateral mydriasis. D, new focal motor deficit. E, herniation syndrome. And imaging schedule, it's very important because normally we are not sure when to do the imaging. So it is done initially, repeated at 12 hours, if initially done at less than 4 hours, then 24 hours, then 48 hours, and if required in between earlier. So the tier 1 therapy is scheduled hypertonic saline, for example, 4 hourly, scheduled mannitol, for example, 4 hourly, and maintaining normothermia. Tier 2 is hyperventilation, PSO2 of 30 to 35, hypertonic saline by continuous infusion, and increase in sedation. Tier 3 is decompressive craniectomy, high dose IV barbiturates. Tier 4, these are untested protocols where we do hyperventilation, hypothermia, nimodipine, and magnesium. How do we escalate the tier therapy? Escalation of therapy or adding another treatment should be considered for the following. Number one, when there is neuroworsening, that is decrease in the motor score, new loss of pupil reactivity, interval development of pupil asymmetry of greater than 2 millimeter, new focal motor deficit, herniation syndrome. 2, no improvement or worsening on follow-up CT imaging. 3, no acceptable response to initial therapy. So this is a protocol which we follow. It will be difficult for you to see it here, but if you check it in a document, you'll be able to know what this is trying to say. Basically, it is when to increase the therapy, when to continue the same, when to do the CT scan, and when to look at whether we want to wean the patient. Now, the weaning, the Krivai's decision support matrix, very important. At the moment, because we are not measuring ICP, we are not sure when would be a good time to wean the patients. So this protocol shows, this matrix shows how you can safely wean. So green is safe to wean, yellow is caution, and red is do not wean. And you can see in the first 24 hours, mostly it is either do not wean or use caution to wean. And then in the next 24 hours and 48 hours, not to wean comes down slowly, gradually. It all depends on the GCS score, on the pupil reactivity, etc. And then in 72 hours, you can see that the not weaning becomes much less, and the weaning and the caution wean increases. And after 72 hours, you can easily wean off using some caution. So I think it's very important to look at that. Now, what I discussed with Salman the other day, and I thought maybe some centers or as many centers as possible could sit down and propose a study to see whether we can look at these 3 ways of treating our patients in lower and middle income countries and come up with a protocol looking at the Colombian protocol also and this protocol, and come up with some document so that we all can follow this thing. Now, we know that rehabilitation is one of the most important parts and which is often neglected in developing countries due to poor resources. We know that it has to be a multidisciplinary thing. There's a role of DBS, but we know that in the lower and middle income countries, there is very little resource regarding rehabilitation. So the role of family members is very important in this thing, and we have been training family members, and as I said, there was a paper from Aga Khan University Hospital also regarding how to make it a proper protocol to train the family members in giving rehabilitation. As you can see here, this study also from Asian Australasian study which we did, that majority of the rehab is given by the family members. Many other initiatives which we are doing, and one was launched as the Comprehensive Policy Recommendation for Head and Spine Injuries, CARES and LMICs. This is a recommendation for policymakers, and it was launched last November in Peshawar, and it's called the Peshawar Recommendations also. This, and if we look at how we are going to proceed, and we hope that by the WFNS Bogota meeting, we should have made some action in that. And this, along with the new Global Neurosurgery Committee, which was launched last November, is headed by Key Park and Al-Wahabi. And they are doing a great work. So the two combined are looking at how to improve the neurosurgical services throughout the world in the LMICs, etc. And the objectives are to achieve universal access to neurosurgical care and to engage with surgical stakeholders to building integrated surgical systems. So the whole idea is that by 2030, we have a universal health coverage for neurosurgery also. And as you know, the National Vision for Surgical Care 2025 in throughout the world to get universal health coverage, Pakistan is doing the same. And we have managed to piggyback the policy recommendations onto the National Vision for Surgical Care. And we hope that neurosurgical, which two main things, ventriculoperitoneal shunt and craniotomy for trauma, are included into this national vision for that. You know that we have a very less number of neurosurgeons, and 22,000 surgeons are needed in LMICs to improve services. And there's a question of looking at whether you would like to train non-neurosurgeons and control them through Skype, teleradiology, etc. We are hoping to host the 6th International Neurosurgery Resident Course in March 2021, if things are well, and we look forward to all the young neurosurgeons to be coming for this meeting. Thank you very much. Thank you.
Thank you, Tariq. I think that was brilliant. Enjoyed that. Obviously, what's required in our part of the world and compared to the Western world is completely different. Our moderator, Laura Lippa, has joined us. Laura, good to have you there.
Yeah. Hi, I'm happy to be here. Sorry for the delay, but I was off the night shift. So I just came in time to hear the wonderful speech of Professor Khan. So I'm glad and I managed in time. And there are a lot of things to talk about if we want to start a discussion. That I think there are all kind of novelties in right now in literature, both the Crevis and the CBIC poster that just came up. So we have a different kind of approach, which is stepwise in some kind of guidance in management of ICP monitoring and ICP monitoring when you don't have ICP monitoring. So how do you manage? I'm very interested because in my department, we are a trauma center, but we have a bigger one nearby. So we just have an ICP monitoring and sonography. So how do you, all people in this wonderful, but we have 84 participants right now, so it's a lot for a neurotrauma webinar. It's amazing, I'm glad. And I would love to know how you're managing from everywhere where you are, all the way you're managing ICP, because you're measuring and managing, if you can measure it.
Okay.
May I add here, I came to Pakistan in 1990 after spending 10 years in Ireland and mostly in Belfast, which was a big trauma center for neurosurgery. And we were doing ICP monitoring at that time using interventional catheters and leads, screws, etc. When I came to Pakistan at that time, really we didn't even have a proper ventilatory support or proper intensivists at that time. And I found the most important thing which helped me was to do an immediate tracheostomy for the head injury patient. And that I found that really helped those patients because they improved their oxygenation, etc. But we have come a very long way now. There are many centers in Pakistan, and I'm sure in lower and middle income countries now, who are doing ICP monitoring. And this talk which I gave basically was to get an idea and to discuss with people, if we do not do ICP monitoring, how can we rationalize our management system? And I found Randy Chestnut's groups, this protocol very interesting. And I started this protocol last 3 months. And I would like to study with my friends to see, look at a decompressive craniectomy straight away, a patient with ICP monitoring and their results, and doing the Cree-wise protocol, and at least see whether it reduces, which one reduces stay in ICU more compared to the other.
Yeah,
Okay,
sure.
so
Yeah.
there is a question from Dr. Larry, and who's asking, what is the surgical removal optimal time on golden hour associated with best outcome of expensive hematomas in head injured patients?
Sorry, best, it depends on what you have. Like, I mean, you've got an extradural hematoma, whether you've got an acute subdural hematoma. Of course, it's obviously with an acute subdural hematoma, you have to go in very fast and do it. And the results, as you know, are not as good at all for an extradural hematoma. I'm not sure exactly what he means by the golden hour for removal of a hematoma. I think
basically this was a big question he was asking, and he started by
Yeah.
what stage you'd perform urgent evacuation, initial operation for mass lesion when the swelling is encountered or anticipated, or maybe a different tier therapy when other medical management has failed, or a second tier therapy with initial measurements, sedation, ventricular drainage, mannitol not effective. When would you do it is their question.
So
Non-specific question, actually.
okay, I gave three ways of what we are practicing. The first one was that if the criteria are there with a midline shift of greater than 5 millimeter, with effacement of basal system with GCS of 9, we would like to get it done as soon as possible, as soon as the patient arrives. If not, and if you can do with ICP monitoring, and if the ICP remains high over 22, then for a period of half an hour to 1 hour, then it's better to go in and do a decompressive craniotomy as well. The important thing is not to be running after your tail, because once the herniation occurs, then literally, you know, you're chasing your tail and you cannot really get anywhere. And the third option, which I suggested, is something which is worth looking at, do the Cree-wise protocol, because at the moment, we are not sure what we are doing. We are giving mannitol and then we are doing a CT scan. And so maybe some semblance may come to, some method may come to this treatment protocol by using that, which is my recommendation or suggestion.
I think I totally agree what Professor Tariq is saying, that, you know, many centers in our part of the world have to get together, come up with a trial, and we can follow the previous trial in various ways. We can adjust things according to our need, which Tariq has already done in his center, and then we can have a bigger study out of it and come up with very good numbers and very good results, because majority of the time the problem is happening in lower middle income countries. And, you know, the services are required and the data is required from our part of the world. So I think we all need to get together and do this. Agree with that. Laura, you want to take? Yeah, you want to take?
Absolutely.
You want to
yes,
take that?
So we have Dr. Arianta from East Borneo. So he has a question for Dr. Khan. In patients with severe TBI, management is needed to maintain ICP and CPP, one of them with head of bed elevation and body position, especially in primary care. What is the most recommended head bed elevation degree, and what is the best body position to achieve optimal CPP without increasing ICP?
Yeah, so obviously 30 degrees elevation of the head, and making sure that the neck is not flexed too much. That's very important. We have seen patients with the neck flexed, which can cause compression of the carotids, and which can lead to also respiratory problems, and also with problems for the raised ICP. So it has to be a neutral position at 30 degrees. The right thing.
Yeah. What do you think about applying the next criteria to avoid cervical collars or overtreatment in this case? So we see it happens that we have this strict protocol that our ambulances are with volunteers, so we have people that they got a collar no matter what. So, and no matter what means that they got a collar from no matter who. The training is, yeah, it's a good training, but still. So we can find these people like, you know, reddish, and the ICP is sky high, the jugular. So this is something
better to have sandbags on the side is a better way to do it than putting a collar which can compress, you know, if you get overzealous. Of course, having a proper collar on in the right fashion is very good.
In the right fashion. So then we have a question about sedatives. So which sedation is most effective in traumatic brain injury, which have least side effects? Or I would ask to Dr. Ali, do you mean sedation like sedation for an intubated patient for severe TBI, I guess? I don't know.
You should answer that, Laura. I think he's talking about trying to sedate the patient and paralyze the patient possibly.
Yeah, so basically this is something that we do not control. Basically, this is something that it's mainly anesthesiologists, neuroanesthesiologists. But I know that somewhere in Pakistan, we have someone who has an excellent department who does all by themselves. So we met during Icon in Peshawar. One of your former residents, now I think she's graduated, and she was telling us about the wonderful work they're doing by managing patients all by themselves from intubation on. So this is very peculiar, and they certainly have so much to teach us on the matter, but this is something for anesthesiologists. So we basically are with them, but we let them do their magic. So they're the magicians with.
I think the advantage of having the ICU under care is that then you do things according to your plan, and you don't get surprised by the anesthetist many times who are thinking in the line of people with pneumonia and people with chronic diseases who are on ventilator. They're completely different from head injured patients. So unless they're looking after those head injured patients a lot, then they actually become a hindrance instead of benefit sometimes. So you need to have a unit in which lots of head injured patients are coming and they're managing it, they're doing it as a team. And they understand your wavelength, when you want them out of the ventilator as soon as possible. You want things done your way, and you want, obviously, if any change happens, you want a scan done, stat, that kind of thing. So all that, if you have good coordination, then it works very well.
There's a question regarding the importance of EBD in severe traumatic brain disease. Of course, EBD has got a good role. EBD has a role in, first of all, you can monitor the ICP, and also you can remove small amounts of CSF, which you would see suddenly would drop the intracranial pressure. That is if you can get into the ventricles. Sometimes it might be very difficult with squash ventricles, but I think with experience, you may be able to insert a EBD in many patients in severe TBI. So it is of benefit, definitely. Okay,
there's a question regarding intubation during COVID time. And we know that this has been written in neurosurgery and in Lancet as well. And the guidelines clearly say that if you're intubating patient or if you are suctioning on a patient, you should use an intubation box. An intubation box is either made of glass or plastic, and you can put your hands inside, and it's a closed space towards the person who's putting in the tube or who's sucking, doing suction. So with that intubation box, it's covered on 3 sides, and one side is a flap. And the idea is that all those fumes that come out during intubation, you do not inhale them, but at the same time, you do take precautions and you wear proper mask and gear. PPEs should be properly worn at the same time. So the intubation box, you can, if you just search, you can see YouTube videos on that as well. On top of it, it's in Lancet of last month. So people can look that up and easily recover that. And any more questions, Laura, you'd like to ask before we wrap up and get Imtiaz Tariq to speak?
Okay, this one that came up in context of LMIC settings where hypertonic saline is not available everywhere. What is your advice about to use? So well, we know now that not everybody is comfortable with both hypertonic and mannitol. So historically, it was mainly mannitol, okay? But other than this, if you don't have hypertonic, you can switch to mannitol. I don't know, once upon a time, there was use of glycerol in my unit as well. So right now, we do use just mannitol and hypertonic just under our supervision, because our intensivists are comfortable with it.
Yeah, I think with hypertonic saline, if you really want to use it, who's that, Laura?
Yeah, it's my daughter. Say hello. There's a lot of people who want to say hello to you.
Hello. Good to see you. So what's her name?
Dharma.
Okay, Dharma. Dharma, you're beautiful.
You say thank you. Digo, bye.
Okay, so because monitoring is very important when using hypertonic saline, and you need to make sure that it's not sodium doesn't come up too fast. Right. Otherwise, you can cause more problems than benefit.
You need to have really a close look on this. Yes.
Yeah, sure. Yes, Tarek, your comments, and then we'll move on.
Yes, I agree. I think first of all, 3% saline is not available. It's, I think, only available in Karachi, maybe in Pakistan. I'm sure it's the same in other LMICs. Mannitol, and of course, you have to monitor very carefully. But
Tariq, I thought everything is available in Peshawar. Even whatever you want is available. So, hypertonic saline, I'm sure you can easily get.
Yes, we have asked for it, and they're trying to make their own here in Peshawar, and many other things.
Okay, Laura, would you can shall I introduce Tariq, or can you introduce Tariq if you like? Tariq Imtiaz. Oh, we just need to unmute yourself. What happened here?
Okay.
Yes, Laura.
So we have next talk is from Professor Imtiaz, and it is something that I really looking forward to. Cranial neuromonitoring, so neurophysiology in brain surgery, which is something that we're never talking enough, I think. So I'm eager to listen to you.
Thank you very much. Can everybody hear me?
Yes, we can.
All right. So yeah, before we're going into those, one of the questions was about propofol and ketamine, and we're using propofol here. And a lot of neurophysiology monitoring that we do in neurosurgery also is dependent on propofol, or we call it total intravenous anesthesia. I'm not going to talk about that in my talk, but there is a dire need for neuroanesthesiologists, especially in the developing world, to understand total intravenous anesthesia, and especially propofol. Now I'll come back to my topic, cranial neuromonitoring. So I've just expanded this topic into neurophysiology monitoring in brain surgery. And I work in King Fahd Medical City, which is an accredited center, the only accredited center outside of the US. There are some of the big names there as well. All right, so, well, President Reagan in 80s called one of the neurosurgeons as world's best neurosurgeon, and he sent him a handwritten note. And that surgeon was Fred Epstein, one of the legends of modern day neurosurgery. And he was the pioneer of many things, especially he was famous for intramedullary spinal cord tumors and brainstem tumors. So I would like to just show you my connection with neurosurgeons and neurophysiology. And then what happens is that one of his fellows was Rick Abbott. And I was fortunate enough to work with Rick Abbott in New York. And Rick Abbott is one of the major proponents of neurophysiology monitoring in the US. And I was lucky enough to have actually worked with him in all sort of brain and spine surgeries. And when Fred Epstein was asked about what do you do best in your place, at your place, and he said monitoring and mapping is the best thing that we do here. Now, when I go to neurosurgery conferences, a lot of time I've been asked about literature in neurophysiology monitoring, and I understand we do not have that much of clear literature with class 1 evidence. But I was just going through something about neurosurgery and levels of evidence in the neurosurgical practice of certain things that neurosurgeons do in their practice besides neurophysiology. And I found this, the class 1 evidence that has been followed in major neurosurgical procedures is only 2%. And most of the evidence is class 5 evidence or class 3 or 4 evidence. So 90% of neurosurgical practice, I know I'm going to ignite a lot of neurosurgeons, but this is what literature says about evidence. So what is the evidence that we have? We also do not have much evidence, only a few studies with class 1 and class 2, and most of them are on spine. But still, neurophysiology monitoring has been practiced worldwide, and many papers are published talking about the positive aspects of neurophysiology monitoring. So I would not go into those aspects because the time is limited, but I just want to highlight this slide, which talks about cost of disability in low-income countries. And I think most of my audience right now are in low-income countries or developing countries. And this report came out from the United Nations that if you have a patient paralyzed in a developing country, the cost that the nation endures is much higher than developed countries because of the lack of infrastructure. Hence, preventing disability is very important. And I think Professor James Rutger recently came out and he talked about trillions of dollars would be lost in disability in neurosurgical practice. So neurophysiology is one modality that actually prevents disability, and that's where the crux of my talk is. So the objectives of my talk is I'll briefly talk about what is neurophysiology monitoring, and then some of the modalities that we practice. In some cases, we will discuss with the images. Right. So what is neurophysiology? Why neurophysiology monitoring? As we briefly discussed, prediction of outcome, monitoring of nervous system in real time while the surgeon is operating on a tumor in the brain, for example, and then timely detection of injury, even preventing injury. This is what we do mostly in our facility. We try to preempt things and try to prevent injury. And then, of course, if the injury happens, we try to do neuroprotection by reversing methods of talking to anesthesia, mean arterial pressure, and then helping in optimization of surgical outcome, even in very high-end and complex procedures. So the next question comes up, what is neurophysiology? For those who have not been familiar with the techniques, it is the use of electrophysiological techniques that identify certain pathways, location of generators, for example, sensory motor homunculus. And this detection is done quickly within milliseconds. So the surgeon has immediate information available to him during procedure. And then that information can be translated into whatever the surgeon wants to do to protect that injury. So what are those tests that we do? So before going to that, some of the advantages of neurophysiology monitoring, as I've highlighted them in the red. So a lot of times the bleeding can be one of the major cause of concern for the surgeons, which is not directly surgeon's job to control it. Anesthesia is doing that. So, we don't bother surgeons when we see that the problem is caused by bleeding, which anesthesia can do something about it by, increasing the mean arterial pressure or giving blood. So I've just briefly given you some of the advantages. I'm not going to go into those details. So what are these modalities? Well, actually, before that, the brain surgeries that neurophysiology monitoring has been used worldwide. Since my topic is mostly brain, so I'm not going to go into spine procedures. So these are the procedures that we follow in our practice in Riyadh, Saudi Arabia. And most of these surgeries, we would be using neurophysiology monitoring, even aneurysms, and also some neuroradiology procedures. If you see at the bottom, where coiling or balloon occlusion of, say, internal carotid artery is done. Okay, so some of the modalities. The modalities that are probably most important and mostly used wherever neurophysiology monitoring is practiced are labeled in this green, where you're seeing somatosensory potentials from upper and lower limb and transcranial motor evoked potentials. And then we have in blue electromyograms and triggered electromyograms, these number 3 and number 4. Number 3, especially in brain, it is used for cranial nerve monitoring, and a triggered electromyogram is a modality that stimulates a nerve and you identify whether the nerve is intact from proximal to distal. And then we have EEGs and electrocorticogram we use for vascular procedures and epilepsy procedures. Magnetic encephalogram is a new addition, although not used in the OR, but we use routinely for more information for following tumors. So all you see in pink are the most advanced modalities that is part of neurophysiology monitoring. So number 5, number 6, number 7, depending on the depending on the location of the tumor and approach by the surgeon, we use these modalities as well. So I'm going to give you briefly what are these modalities, because most of the residents probably would not have seen them. So just to give you an idea, and your take-home message would be to understand these modalities and how these modalities have been practiced and brought into the brain tumor surgery especially. Now, before I go into that thing, 2 important things to remember for all residents is whenever you have a test, you have a stimulation and you have recording. So you stimulate somewhere and you record somewhere. And then stimulation has certain stimulation parameters. And I've highlighted these parameters. This is not for you guys, but just to understand that the results really matter if you understand all of these parameters as well. And you would see a number of times, in especially neurosurgeons, talking about that, my neurophysiologist did not give me relevant information or told me something, although the patient woke up with something else. This is because these parameters have not been understood by the technologist or the physician, and that is resulting into false positive. Hence, so your results would be depending a lot on these parameters. Now, as we discussed, the top 2 modalities, somatosensory evoked potentials, and so I've given you my own template. You see on the left side of your picture, somatosensory evoked potentials in the upper limb. We are stimulating a peripheral nerve at the wrist. If you see the arrows here on the hand, and then we are recording, because sensory system is an ascending system. I'm not going to go into the pathway. Is an ascending system and you record from the generator on the somatosensory cortex, as you can imagine, the Penfield homunculus. So we try to place electrodes, which we call recording electrodes. So you stimulate on the wrist and you record as the signals go up. You can record at the brachial plexus, you can record at the brainstem level, and then you can record at the cortex. We call the somatosensory generator, or the primary sensory cortex. And when you stimulate a certain area, I'm not going to go into those parameters. When you stimulate using electrical current, what happens is the waveforms can be recorded, and the waveforms have a morphology or a shape or a size. We call this amplitude. And then these waveforms take certain amount of time to reach those areas. We call them latency. So assuming in the brain tumor, the latency around brainstem, if you stimulate a wrist, is about 13 milliseconds. And then from brainstem to somatosensory cortex is about 20 milliseconds. So 7 more milliseconds. So imagine if the surgery is around between brainstem and somatosensory cortex, say for example in thalamic area, the wave that you record at 20 milliseconds would be deteriorated either in latency or with the amplitude, but remaining waves would be okay. So this is how we help the surgeon in brain surgery. And similarly, we have lower limb somatosensory evoked potentials where we stimulate the posterior tibial nerve at the ankle, and then we record the signals as they go up. And we can record from spinal cord or brainstem or at the somatosensory cortex. So stimulation at the periphery, recording in the central nervous system is somatosensory evoked potentials. The opposite is transcranial motor evoked potentials. As you know, it's the descending pathway. So where stimulation is done by electrodes at the brain or at the scalp, and recording can be done at the any muscle where you can place electrode and you record muscle. You record CMAPs or muscle action potentials from there. These 2 tests are integral, and in all brain surgeries we do these tests. We cannot do comprehensive neurophysiology monitoring without these tests. Just a disclaimer: if you have a patient with the McCormick grade 3 and 4, likely the patient is not moving much, you would not have transcranial motor evoked potentials, or you would have very poor transcranial motor evoked potentials. So the idea for a comprehensive monitoring and helps mostly patients with grade 1 and grade 2 McCormick grades in clinical motor power. So that's just to understand these things. Now, mapping. Before we go into mapping, what is exactly mapping and monitoring? Monitoring is when you check the functional integrity of an established system, for example, somatosensory evoked potentials. But mapping is localization of a structure, not the pathway, but the localization of the structure. For example, where is the brainstem nuclei for cranial nerve number 5? For example, where is the hand area on the primary motor cortex? That is called mapping. And how we do it, we stimulate that area and we record from relevant innervation where that area is controlling. So we have stimulation from that area, recording from the relevant area, and then that's how we identify that this is the localization of a particular structure, for example, hand area and motor cortex. So I'll go into primary sensory cortex mapping. We also call it sensory mapping. We also call it central sulcus mapping. We also call it phase reversal mapping. So imagine this is the slide and you are seeing a tumor. This tumor is highlighted in this blue. And what happens, this tumor has obliterated the central sulcus. So now you do not know where exactly the central sulcus is. So what we do here is, we do something called sensory mapping by, if you see the bottom picture where we have placed an electrode, which is mostly a platinum strip. And what happens is, then we do a sensory test from the contralateral upper limb. So this area, this recording electrode on the brain, which is a platinum strip, records signals from the contralateral upper limb sensory, somatosensory evoked potential, say median nerve stimulation from the contralateral wrist. And then we record signals there. What happens is these electrodes, each electrode record a particular morphology or particular polarity of signals, which means a particular waveform is formed. I'm not going to go into those details. This is basically for other neurology topics. But what happens is, if you see number 1 and number 2, the first deflection that you're seeing is downward and then going up. But if you see number 3 and number 4, the deflection is going up. So here between number 2 and number 3 electrodes, you are seeing a reversal in the polarity or the morphology of the wave. So that's how we communicate to the surgeon that the central sulcus is located between 2 and 3. And the number 2 is likely the primary motor cortex, and number 3 is likely the primary sensory cortex. And this is how some of the examples that you see, that's how we monitor the central sulcus. Now, how we do primary motor cortex mapping, once we have established that where is the central sulcus, the same electrode we can use for stimulation of now primary motor cortex. So for example, if the surgeon wants to stimulate the hand area or the face and arm area, we communicate with the surgeon, we record from hand muscles, contralateral hand muscles, and then each recording is again depicted on our screen as CMAPs or muscle action potentials. And we tell the surgeon that if you're stimulating area number 2, that is, you can see on the red, we are recording signals from hand area, or 3 also hand or shoulder area, 4 we can record from lower limbs areas, and that's how even number 1 for face areas. This is how a waveform, if you see on the top left of your screen, when you stimulate a hand area, this is how you identify a hand response from hand when you stimulate, say, area number 2 in the red. So this is how you do motor cortex mapping. And this is done in microseconds. So if you're wondering how long does it take, when you stimulate, from stimulation to recording it from hand, it takes about microseconds for the signals, microseconds to milliseconds for signals to reach. So under a second, you can have a response. So you can immediately notify this to the surgeon that you're working on the hand area. So just be careful, or whatever needs to be done. So similarly, speech mapping can also be performed. And I'm just going to give you some examples of how somatosensory cortex, how accurately you can actually monitor somatosensory cortex by these slides with MEG confirmation, MEG and electrophysiology confirmation. You can see here, we have very precise location, and a lot of surgeons still consider electrical brain mapping to be the gold standards, although they still have functional MRIs beforehand. but still electrical mapping can be very accurate, especially in brain surgeries. I'll show you more about, if you can see more images of sensory motor areas, very precise location of those areas can be easily identified using electrical mapping. And if you have MEG that we have, so we can also have more very comprehensive information even before surgery. Now, language areas again can be mapped, and there is a technique to map language areas, especially in awake craniotomies. In our hospital, we'd only do it in left side. We do awake craniotomies mostly only on left side tumors, but some surgeons prefer to do it even on right side where hand areas are present. And there is probably a acceptable reason for awake craniotomies on the right side hand areas as well. And I'll show in our slide. This is from our MEG data, and this tells us that you still have some right hemispheric language lateralization in some patients. So, it's up to the surgeons, but mostly we do MEG and we do language lateralization, and then we bring the patient in the OR and we do electrical stimulation for language areas. Now, also for epilepsy surgeries, if you tell the surgeon that these are all in red epileptiform discharges, the surgeon cannot take out all these areas. So epilepsy surgery is also another domain of neurophysiology monitoring. And by exact localization, you can actually precisely, with deep settled electrodes with MEG and direct electrical stimulation, you can identify the precise location of those epileptiform discharges and contribute to the overall benefit to this patient. This is just a video I'm showing you about an EEG for a patient. And if you see the idea here is to identify the first triggering spot. So if you see here, that was on the top left bottom around 49 and 50. That is where the first triggering electrode came out that started the seizure. So that's how, if you give surgeon this kind of an ECOG, electrocorticogram, surgeon would not be able to do a good epilepsy surgery. So again, localization easily done by neurophysiology techniques. Now we can, very demanding and very, I would call a new topic is subcortical mapping that we have started following for long tracks or white matter tracks in the subcortical areas in the brain. Remember, we've talked about the cortical mapping. Now, even subcortical mapping can be done continuously by giving the surgeon electrodes and remember again, stimulating those electrodes, and if those electrodes are hitting the white matter tracts, recording from those white matter tracts are contributing to those areas, recording from those areas, and then in that way you can identify and help the surgeon not damaging the white matter tracts. So, and then the cutoff criteria that has been established is 1 milliampere. So if the surgeon is 5 millimeter away, you normally would get a response from relevant white matter tracts at about 5 milliamperes. As the surgeon goes deeper and deeper towards the white matter tract, obviously you can imagine that the intensity would be less. So the cutoff is 1 milliampere. The moment you start seeing responses from white matter tracts at 1 milliampere, you would stop. In our practice, at our facility, we do it at about 2 to 3 milliampere. So we don't want to take the risk of going much deeper or much closer. So what I want to tell you is that in deep-seated, white matter tract tumors, you can also do subcortical mapping. That is also continuous, takes milliseconds, and you can get responses immediately. And I'll give you some of the examples. This is high-grade GBM that we have done. During the surgery, we did 3 intra-op MRIs. And then eventually we were able to do this kind of a resection. And the surgeon only could do this because he had the availability of comprehensive multimodality neurophysiology monitoring. This is another example of a high-grade glioma, and where we were able to do subcortical mapping. And as you can see in the top picture, on the top of the screen, top left, where we are mapping one cranial nerve, and then you're monitoring if you see a second picture on the left, we're monitoring multiple cranial nerves, 5 or 6 or 7 cranial nerves. And then if you see the summary, you can see how deterioration in the size of the waves is happening during surgery by doing subcortical mapping. And that's how we were able to help the surgeon that, okay, fine, this is deteriorating too much. and in more than 50% deterioration, we would like to ask the surgeon to stop. Otherwise, this patient may lose those functions. So again, you can see this is cortical spinal tract mapping when you're stimulating the white matter tracts for the limbs. Previous picture was for the cortical bulbar mapping. As you can see here, the size of the amplitude before tumor resection started versus during tumor resection. You can see the deterioration in the size of the waves. That's how we are able to predict deterioration. Again, cranial nerve mapping is done mostly, and I would like to emphasize, I think, especially in developing countries where you're using a system which is an automated system for monitoring, please also remember that you are placing these electrodes on for facial muscles for, say, cranial nerve number 7 or cranial nerve number 5 or 3rd or 4th or 6th. Please note for 5 and 7 especially, the recording, whenever you are doing this, ask your neurophysiologist, what is the latency of response that you are getting for, say, cranial nerve number 7? The response for cranial nerves should be under 1 milliampere, sometimes even be 0.1, 0.2 milliampere. So you can imagine very, very tiny current is given, does not bother, does not hurt any nerve. But once the nerve is stimulated at the brainstem level, it takes about 7 milliseconds for facial nerve to transfer signals to the to facial muscles, for example, orbicularis oculi or mentalis. So if you're seeing a response at 3 or 4 milliampere, that is not a facial nerve. So not just the intensity of stimulation is important, but latency of stimulation in cranial nerves monitoring is also important. So all those surgeons who are doing this with the machine or automated machine, or they do not have the services of a trained neurophysiologist, I think they should focus on that. And if you see the last picture, you can see here we are monitoring 3rd, 4th, 6th, 5th, and 7th cranial nerve, and all these electrodes are placed. And mostly I do bilateral, all these cranial nerves, and after talking to the surgeon if he needs these cranial nerves monitoring. Again, I'll show you a video of, this is an epidermoid case, and I'll just play this video. It's very simply, if you see here, this is the electrode, this blue color thing is the electrode, and he's stimulating, I think probably this is the trigeminal. So this stimulation, he just touches the nerve, and we record from the relevant muscle, for example, masseter supplied by trigeminal, and then I think on the right is facial, and on the left is the trigeminal nerve. So what happens is that while the surgeon is touching those nerves, most proximal to the tumor, we stimulate and we record from the muscle. So please make sure that when you're stimulating the nerve, you are stimulating proximal to the tumor, not distal to the tumor, because if you're stimulating only distal to the tumor, to the nerve, and the nerve may be damaged proximal, and you may be telling the surgeon, yeah, the nerves are fine, and you're seeing the responses, but the nerve might have been damaged proximally, and you would not, the patient would wake up with deficits. So this is how we do cranial nerve monitoring. I'll move on just for the sake of time. This is how, if you see the screen here, this is the EMG screen that we use for when we stimulate these nerves. We record from these muscles, and the test is called electromyogram. If you see the left side, there are many muscles on the left, and then on the right there are muscles. If you see the irritation happening in blue on the right side, say facial nerve. So I just want to show you, for those surgeons who do not know or who have not seen this, this is how an irritated nerve looks like. And simple thing, what we do is whenever we see this irritation, we just use cold irrigation, and the nerve settles down, and that way we're preventing a continuation of this irritation, resulting in post-operative transient deficits to those nerves. So just simple cold irrigation helps in these cases, and just by identifying these EMG changes. Now, I'll give you another example where we have this internal carotid artery aneurysm on the right side. She was a young patient, 38 years old, and then she had headache and diplopia. And when we did the, if you can see this video of if you see this angiogram, she had a big right side ICM aneurysm. So we decided to do, not a surgery, we decided to do first balloon occlusion. And once we were monitoring the sensory motor pathways for this balloon occlusion, and if I would like to show you in the next slide that no changes happened in the motor pathway. No changes happened in the motor test in transcranial motor evoked potentials, but only the left side somatosensory evoked potentials. If you see, this is the left side. If you see that there is deterioration happening on the left PTN what is deterioration? We are losing the amplitude, we're losing a pattern of waveforms. And if you see on the right side, the motor evopotential state stable. So you can imagine that very precisely we were able to identify we were able to save patients from any deficits. And post-op, when I asked the patient about what she felt like, and she said, I'm not feeling my left leg. I'm feeling like my left leg is not doing well, although she was moving it. So you can imagine that, this is how precisely we're able to monitor certain functions in these kind of vascular surgeries as well. And we do these tests also in aneurysms. I'd like to finish my talk. I think I was on time. This is the handwritten note by Fred Epstein. He was injured and he passed away eventually, I think, because of that injury. And he wrote this note with his not right. I think he was a right-handed person, and he wrote this with his left hand. And so I'm just ending this talk on this slide, just emphasizing that neurophysiology was actually first taken into the OR by surgeons. If you go back into history with Penfield, and then coming back into modern day neurosurgery, Fred Epstein was one of the legend surgeons who actually contributed a lot to the neurosurgical practice by introducing neurophysiology. Now it's being widely practiced. I hope in this limited time I was able to give you a brief summary of certain modalities and how these modalities are applied in brain tumor surgeries and some other vascular brain surgeries as well. I would be happy to take any questions. Thank you.
So that was great. Thank you very much. Thank you very much. And the moment you start monitoring during surgery, you won't stop. I think this is the point. The moment you start, you will want to monitor everything all the time because it gives you so much insight about what's going on. So we have a lot of questions actually already.
Sure.
The first one is from Dr. Al-Satuf. I hope I managed to pronounce it right. During resection of the tumor, is there any false positive recording during monitoring?
Yes, that's a very good question. See, as one of my slides, I talked about the stimulation and recording parameters. If you are applying correctly, let me give you an example. Say, for example, you're working on a left side motor cortex tumor. And obviously your concern is right body. And you're stimulating left motor cortex. You have done mapping, you have done sensory mapping. You are on motor cortex. Everything you are doing it all right. You have correctly identified the hand area of motor cortex. But for example, your stimulation now, while the surgeon is removing this, say, glioma on the left motor cortex, you have increased a higher threshold. You are using a higher threshold intensity for stimulation of the hand area. So what is happening now is your aim should have been only to stimulate the hand area generator on the gray matter. But if you're using a higher intensity stimulation, now your current is going deeper below the tumor, exciting the below the tumor pathways, and then you are recording from hand area on the contralateral side. Now you're telling the surgeon, yeah, I'm still getting hand, keep operating, keep taking the tumor out. But actually, the damage he has already done, at the gray matter. So when the patient wakes up, he cannot use he has to use his gray matter on the whole conduction pathway. So yes, if you do not use the modalities correctly, you can produce false positive. But if you understand what exactly you are doing, it's easily preventable. You will be surprised that in my practice, we hardly see false positives. It can happen. So short answer is yes, yes, it can happen. That's why if you are, experienced hands would prevent these kinds of things from coming up.
Thank you. I think that was the perfect answer for this question. The question was continuing, I think, in asking if the surgeon, a false positive would make the surgeon afraid to continue and achieve complete resection of the tumor. So basically, yes, but I think that even in this case, the point is that you don't want to achieve a false positive because you can injure the path. So this is the point of
that is true. That is true.
Use.
Yes. You see, when you can get comprehensive results when you have a good communication with the surgeon. For example, in say a high-grade glioma, where your aim is say 70 to 80% resection, and the neurophysiologist understands that. So you, like in my practice, we try to go as much close to the aim of the surgery, not by producing false positive or false negatives, but truly communicating to the surgeon, yes, there is deterioration happening, but 20%, 30%, 40% deterioration. He understands that. And you'll be surprised, the more surgeons understand neurophysiology, the more they actually love it. And in our practice, sometimes surgeons would not do a surgery if neurophysiology is not available. Yes, sometimes you can create unnecessary alarm. So that comes with how different surgeons have different mindset. Some surgeons want to know exactly even tiny little things happening. Some surgeons would just tell you that, okay, fine enough. I just want to know whether I am really seriously causing damage. So in my practice, I would not bother surgeons too much for 10 to 20% deterioration unless he wants to know it. But yes, you can create these kind of alarms. But again, coming back, if you have your parameters correct, you can prevent all these things from happening and unnecessarily causing tension to the surgeon.
Brilliant. Tariq, have you got any comments, please?
Hi, excellent talk. Thank you very much, Tariq, as usual. Two very important things which we said was, one is the cost of disability. I think that's the most important thing people have to understand, the governments have to understand. If the governments understand, they would be able to supply neurophysiology equipment and neurophysiologists, which is a very difficult people to get by here. Also, I think applying neurophysiology to surgeries would make the surgeon's life much easier. And of course, it provides great safety to the patient. So I think it's very important. And with time in lower and middle income countries also, it will become the norm. And we hope the sooner the better. Thank you.
I think that from our aspect, the issue is that if we can, this is a matter of physiology, and physiology that's being picked up by wires, and it's a small computer, and the cost, unfortunately, because of various reasons, is unbelievably high, and maybe locally made systems could improve the scenario, but you just need to have some uniformity there, and it's very difficult. We have some models which are available in India, but at the same time, those models are difficult to have a uniformity every time, and there are problems and issues with that. So we won't go into that, but I'm sure in future the cost is going to be continuing to come down, and I think more and more people will be able to afford. And there's no doubt that safety is a big factor. And I agree with Tariq Imtiaz that in many cases it should be used routinely.
If you see, Dr. Salman, the cost can be minimized if you understand that the total cost at the end of the year that has been spent by the patient and the society and the hospital on rehab. I would agree that not every case requires neurophysiology monitoring, but a tumor on the motor cortex does require, a tumor on brainstem does require neurophysiology monitoring. Spinal cord tumors, you can prevent those deficits from happening. And if you add all these costs at the end of the year that you are actually those societies or the economies are spending on these rehab, the cost of neuromonitoring is much less than the total cost that comes up at the end of the year. So I would suggest all those hospitals who have very good, high-end programs, and they're seeing a lot of patients with tumors, brain tumors, spinal cord tumors. I think it's still worth it to try and have a system and a neurophysiologist, a couple of techs. And not only it helps that, but also the anesthesia gets a lot of benefit out of it because anesthesia is a very important part of how the neurophysiology team and the surgeons work. So yes, but again, at the end of the year, especially in developing countries, cost is an issue. But hopefully with new electrodes coming up, much cheaper electrodes being prepared locally, probably the cost would go down. But again, I think you surgeons the big bosses in Professor Salman Sharif and Professor Tariq Khan, I think you guys need to take initiative and propose these kind of things into your facilities.
Sure. Laura, your comments and then we close. Can we ask everybody to switch on their video so that we can take a group photograph? Please switch on, everybody switch on your video so that we can have a group photograph. Everyone, please. As long as you're wearing clothes, please. Okay, can you take pictures? All right, and Laura, your comments, please.
Yeah, so the point is that about neuromonitoring. So it's about everything in healthcare and in surgery. So basically neurosurgery is even more because it's more costly. So it all depends on the amount of money governments want to invest in healthcare and in machinery and rehab, and how much the patient does he have to pay by himself. So it also the importance of the universal healthcare coverage, which is like we right now in Italy, we have this wonderful model. So the point is not everywhere is the same, and we have to expect that this will influence the type of care, the type of money investment that the government will make. But I agree that it's absolutely important to invest in rehab and monitoring. If you, the final cost on patients and the society is way lesser in this way. Still, the rehab as much as in trauma, as in monitoring as after trauma. I thank you all for this wonderful presentation.
Yeah, thank you everybody. Thanks, Laura. Thanks, both Tariqs. Thank you, and all the audience. It was wonderful having you. What do we have for tomorrow? Do we have you showing something?
Pleasure.
Just one second. We will just show what we have for. Do we have something? Yeah, we have something tomorrow.
Thank you, Laura. Thank you, Tariq. Thank you, Salman, for hosting all these beautiful webinars.
So
thank you, sir. Thank you for all of you.
Just 1 second. Tomorrow we have Hassan Syed, who's going to be talking about spinal dysraphism. Wow. He's a pediatric neurosurgeon. And we have David Adelson from Phoenix. He's going to be talking about pediatric epilepsy. And moderating this session will be Adrian Chakun from Costa Rica. And we have this tomorrow at 6 o'clock Pakistan time. And then on
both of these surgeries require neurophysiology. Spinal dysraphism and epilepsy.
Okay, fair enough. On Saturday, we have Ramesh from UK, from London. He's going to be talking about endoscopic clival. We need to correct clival lesion surgery. Arthroplasty, and Oscar Elvis from Porto. He's going to be having a second session, and during that time, Nikolai Piv and Shazad Shamim will be the moderators. And on Sunday, we have our neuroanatomy session on cranial nerves 9 to 12. And that is again going to be at 4 o'clock in the afternoon. So we will keep you posted and let you know. Thank you, everybody. It's a pleasure having you all and looking forward to seeing you again.
Same. Yeah, looking forward.
Thank you very much, everyone.
Thank you, everyone.